Welcome to Pregnant Possibilities. I am Jean Schumacher, and my partner is Dr. Deborah Shapiro. She is a board-certified OBGYN, and together we've created a program called the Pregnancy Advantage. And, we have some exciting news, first of all. So we were working on the Baby Advantage, which is going to begin at conception and then take you through your first year, not the baby's life, but your life, because you're going to be going through a lot of changes post-pregnancy. So we have the Pregnancy Advantage to help you get your body pregnant ready, and then the Baby Advantage to help you get through your first year. So today we have a special guest, which is Dr. Mahima Gulati. Oh my God, wait till you hear about what she has done. Woo! She is a board-certified endocrinologist and lifestyle medicine physician working out at Middlesex Hospital in Middletown, Connecticut. And she's authored quite a few chapters on reproductive hormonal disorders and pituitary disorders in men and women. Most recently, one of the chapters is on lifestyle medicine and women's infertility, PCOS, endometriosis, and this was all in an American College of Lifestyle Medicine textbook. She's also published on business of lifestyle medicine, bringing healthier lifestyle to the workplaces. We totally need this. In addition to that, if that's not enough, like, do you have any spare time? Like, really? Like, wow.
Thank you.
She is an assistant professor in the Department of Medical Sciences at Quinnipiac. And one of my favorite places, because right across the street is Sleeping Giant, one of my favorite places to go hiking. Dr. Gulati, thank you so much for taking the time to be with us here today.
Thank you so much, Jean, for your kind and generous introduction. Thank you. I really am honored to be here with you.
Fantastic. We're thrilled to have you. And I have some questions that I know that our audience members would really appreciate getting your expertise on. You do have expertise in both thyroid disease as well as women's health and fertility, but I thought we would start out with a pretty common hormonal imbalance that I see quite often in my clinical practice, and that's polycystic ovarian syndrome, PCOS. And I see it in overweight women, it's more typical, but I also are seeing it in normal weight women as well. And I was just wondering how you describe this condition to patients when you see patients, and also talk about the impact that diet can have on it. And lastly, is it actually reversible?
That's thank you so much, Dr. Shapiro, for asking these really insightful questions. So PCOS, or polycystic ovary syndrome, as you mentioned, is actually the most common hormonal disorder in young reproductive aged women. And it actually has, defined criteria. And there is the NIH criteria, the National Institutes of Health, and then the Rotterdam criteria. Both of them are quite validated. So what PCOS is basically, young women who have irregular menstrual cycles or irregular ovulatory function, as in their ovaries, don't menstruate or produce eggs or estrogen regularly. Other criteria is that they may have androgen excess, which is the male sex hormone excess, and that could be manifested clinically, as in women may have facial hair, unwanted excessive body hair, or male pattern balding or acne, etc. So that's clinical hyperandrogenism. Or they may have a biochemical hyperandrogenism, and either one of those two counts as excess androgen. So biochemical is, where their testosterone levels are frankly high in the blood when we measure their, testosterone hormone levels. So those are typically the two cardinal criteria. And then the third criteria, as mentioned by Rotterdam, is the cysts on the ovaries, which we can find out on ultrasound. And these cysts are typically smaller than a centimeter, so 2 to 9 millimeters, and numerous, multiple cysts. Or they have a large ovarian volume, typically above 10 milliliters. And they can just have 2 out of these 3 criteria, and that qualifies as PCOS. And of course, we want to rule out other causes for menstrual disturbance in these women. So, thyroid disorder or prolactin elevation, etc. So I tell my patients essentially this, that, if they have concomitant, these hormonal imbalances, then they actually categorize as PCOS. And typically it starts at puberty, but in some fewer cases, they can come up, later after, as in they may begin regular in terms of menstrual cycles, but, as they get older, the cycles get irregular. And you mentioned it absolutely correctly. There are lean women who have PCOS. There is a definite subset. It's basically genetic / insulin resistance. So, there are lean women who have PCOS too. And I don't want to go on until, if you had some insights and then I can talk about diet. So anything that you had so far too?
No, that's excellent. Absolutely true. And, it's interesting that it was, first, I think named by, it was the Stein-Leventhal syndrome because of these
That's
two
right.
doctors, and that they first treated it by actually taking out a wedge, right, the wedge resection of the ovary. I don't know how successful that was. Did you ever study that? I mean, I don't know if that really worked, but I imagine, it must have in a certain subset of patients actually worked by lowering hormone levels.
I think there's not a lot of good data out there. I think this was, before we had other methods of treating women. So yeah, interventions, I think largely been given up now, but I'll have to go, but that's a good question. The wedge resection, I know this used to be done.
I was never taught that it was very successful, so I just wondered. But the question is about diet. And you mentioned that the etiology, is partly genetic. So that means that if your mother had PCOS, you're more likely to have PCOS?
Absolutely. It is a, complex, multifactorial genetically inherited disorder. So it turns out, from twin studies and also from just familial studies, if there's a first degree relative, if your sister or your mom had PCOS, then the risk of having PCOS for you is 20 to 40%. Whereas, in general population, the risk is typically 6 to 10%, but it depends on our ethnicity. So there are certain ethnicities like, Native Australian Aborigines have a very high prevalence of PCOS. Certain other races like South Asian or even Mexican Americans may have a higher prevalence of PCOS. And then certain other ethnicities like Chinese or East Asian actually have a lower prevalence of PCOS. But the genetic link is definitely studied. There are certain genes like there's a certain name called DEN and D1A, which, what it means is that the ovaries are excessively productive of androgen in response to insulin levels in the blood. So it is genetically inherited, but also, the reason I mentioned it is lean women who have maybe surplus adiposity around their central, or their waist circumference essentially. So they are, thin outside, but they may have visceral fat. And at least 1/3 or more of, lean PCOS women may actually have this phenotype where they are centrally overweight. And that actually is explanatory of the PCOS disturbance in them.
Interesting. So I wanted, since we're talking about something that's genetic, I'm wondering about, and I didn't really ask you about this before, but about epigenetics and about endocrine disrupting chemicals that might have a role in the future, in your children having a propensity for developing PCOS. Has anyone looked, do you know of anything about I know that they're looking at endocrine disrupting chemicals increasing the risk of later fibroids or endometriosis, but I would think this might be possible as well, sort of upregulating or downregulating a gene or changing the gene expression so that they are more sensitive to androgens. What do you think?
Yes, so I think for PCOS, I'll have to go back and look at the epigenetic literature, but in general for infertility, I think the thing that comes to my mind is a Dutch hunger winter, which you might have come across when you were also looking up the epigenetic part. Is so in 1944 to 45, there was a big famine, and that was called the Dutch hunger winter. And during that, a lot of pregnant women were starved to, less than 1,000 calories a day. And that, it turned out, had a very huge impact on their progeny or their offspring's risk of having diabetes, metabolic syndrome, but also decrease in fertility. And that effect continued for 3 generations. So we've studied that. And so, yeah, there is a big role. Epigenetic, just to clarify, it mentions, basically how do we change how do we turn off or on our genes? So there are, non-DNA molecules in the body that can actually turn on the good genes and turn off the good genes. And they tend to get inherited through the parents into their children as switches. So if my mom had healthier habits, that will imprint on her DNA. And it will carry through. If she had healthier habits as she was expecting me, that would carry through into my genetic pool. And it may actually be inherited to my children. And so that is huge. Our lifestyles are really the determinants of how our genes will behave. And that's been studied a lot for all disorders. And I would imagine PCOS would not be an exception to that.
This is a big part of our program, actually, is trying to affect the epigenome through lifestyle modifications, and as well as reduction in exposure to environmental toxins. So, and that has not really been well studied. I mean, we know a lot about the chemicals causing the problems, but I'm not sure yet that people are doing a lot of interventional studies like our program, but that's something I really would like to do in the future. So now I would like to know whether you think, we haven't talked about AGEs, but we talk about this, I'm sure, but how would diet affect PCOS besides just the losing of weight?
I think this has been studied in numerous studies. There are numerous meta-analyses, there are interventional trials, and of course, there are prospective trials. The biggest thing is fiber intake. I think you had mentioned the fertility diet, the Nurses Health study, which studied more than 18,000 women prospectively for 8 years. These were young nurses, reproductive aged women, and they basically studied their fertility or tracked their fertility and their eating patterns. And it turns out plant proteins, legumes, nuts and seeds, that was one of the big factors. And then there are also lots of other interventional studies. For example, there's a study that had women eat a lot of legumes for 16 weeks, and they really impacted their insulin resistance, their free testosterone levels, their waist circumference, their waist to height ratio, and so on, even their menstrual cycle regularity. So the number one determinant is fiber. And then there are all these other patterns of diet like omega-3 fatty acid intake, folic acid intake, especially through supplements, minimizing our intake of trans fats and saturated fats. Dairy is kind of controversial, and I know we're going to talk about that in detail. But saturated fats per se, there are actually intervention studies. There's a group out of Illinois, Frank Gonzalez's group, that has published a lot of really nice biochemical studies in the Journal of Clinical Endocrinology and Metabolism in PCOS. These are actually interventional studies, and they have studied them. They've actually given them the dairy whipped cream, the heavy cream. They made them drink that and then studied their biomarkers after the ingestion of the saturated fats. And it turns out they have a lot of oxidative stress in their blood. So, their white cells, their free radical actually goes up. Their inflammatory mediators in the blood. So they start making more CRP. They start making more, other inflammatory mediators like TNF alpha, etc., in response to just one load of whipped cream.
Right. And most people are eating that way 3 times a day.
And the important thing is that this is more marked in women who have insulin resistance, which is the hallmark of PCOS. So PCOS already is a place where we begin with like a genetic disadvantage, and the clinical effects of ingestion of dietary non-good products is actually worse in this subset, because insulin resistance leads to a heightened inflammatory and oxidative stress response.
Right. Which I guess is what Dr. Greger was looking at when he did some research about the best diet for PCOS and talks about advanced glycation end products, which is another sort of a chemical produced when food is cooked at very high temperature. Women who have PCOS supposedly have twice as much of the AGA in their blood. Were you taught about this also? Is this something sometimes I think that Dr. Greger in his nutritionfacts.org is an incredible researcher, but he sometimes can dig for some minutia. And I was just wondering if you thought, is this as mainstream understood among endocrinologists or really not? Because I haven't heard anybody else talk about it. I talk about it with my patients, but
no. Unfortunately, endocrine fellowships right now in the country don't really belabor the nutrition aspect as much. Right. We don't talk about nutrition, especially, but this is not a doubt. We do know that processed meats, the biggest source of advanced glycation end products, smoked meats, high temperature, dry heat. And, the biggest culprits are, are bacon and all of those are like really huge sources of AGEs.
Right.
And they have been studied not just in intervention trials, prospective trials, all these cohorts. We know that women who are eating heavy amounts of these that's linked with decrease in fertility and decrease in their insulin sensitivity biomarkers. And that's actually regardless of their BMI. The PCOS insulin resistance is irrespective of BMI. Women are not like forgiven from that.
Right. Have you been able to reverse it? And are you successful in reversing it in your patients if they're willing to change their diets?
So, reversal of PCOS has not been defined. It's not, there are no guidelines that define PCOS, right. But the thing that matters to patients is their health outcomes. typically their pregnancy or reproductive outcomes, and also their metabolic outcomes. So, the risk of getting diabetes or, endometrial cancer or such. I'll go back and I'll lay out that women with PCOS, because they have insulin resistance, which is that their body has too much insulin and it doesn't respond to insulin as well as it should. The body cells, the liver cells, the muscle cells don't really behave very well with the insulin that's in the blood, and they may have higher glucose levels. So they tend to have a very high risk for both pre-diabetes and diabetes. Almost 40% women before the age of 40 will have pre-diabetes. So that's almost half of PCOS women. And 10% or more of them will get diabetes before the age of 40, which is, very scary. Similarly, endometrial cancer, 2 to 6 times higher risk in PCOS compared with non-PCOS women. And many of these cancers are actually before menopause, which endometrial cancer typically happens after menopause in women. So going back to your question about, reversal, these risks can be mitigated just by a healthy lifestyle. I'll give you a case. It's a real case in my practice of a woman who had come to me when she was in her early 30s. And, she had been unable to conceive in her late 20s. So she had gone through clomiphene, which is a fertility or an ovulation inducing drug, and then IVF. She had gotten pregnant first with IVF, but then she lost that baby, unfortunately. Then a second cycle of IVF, and that, was successful. She ended up delivering successfully at 37 weeks. But at this time, she was 268 pounds. So she came to me and her testosterone levels were quite high. The normal women's testosterone levels are 6 to 45, but most women are less than 25. And hers were 59. And when we repeated it, they were like really high, 70 or 80. And then she goes on a healthy diet, stops eating processed foods, starts exercising regularly 30 minutes. She loses, her body weight is now 180 pounds. So that's like 80, 90 pounds body weight loss. And her fasting insulin, when she had come to me, was almost 8. And we cut it off. Fasting insulin typically should not be 8 or higher. That's considered resistance. And her glucose was normal because she was young, in her 20s. So her glucose was 87, but with a high fasting insulin. And that was kind of on the border of insulin resistance. So her insulin went down to 2.9 and her glucose went down, fasting glucose went down to 78. And her insulin resistance is now 0.6, which is actually super insulin sensitive. And she got pregnant spontaneously.
Fantastic.
And so, we and people don't need to achieve that amount of weight loss, right? There are numerous studies which, even 5% weight loss. So for a 250 pound body weight, we're talking about anything from 12 to 15, a modest amount of weight loss actually has been shown for women to regularize their menstrual cycles. And in many cases, bring back spontaneous ovulation. And PCOS is one of the most common or most easily treatable causes of subfertility. I don't even want to call it infertility. Because, women with PCOS get pregnant all the time with or without fertility drugs. And, this healthy lifestyle changes, they do really well with them.
That's a great story of success. And you had a patient who was really willing to do what it would take.
Absolutely. I mean, we put her on metformin, which must have helped her. But, that does not undo the fact that she's been, even during the pandemic, she's making sure that she does her, gym videos online, and she'll do that with her kids 30 minutes a day. And she'll make sure she doesn't eat any processed foods whatsoever. She'll always take the time to home cook. So she did make her effort.
That's great. Just to clarify, because I know people often think all they need to do to lose weight is to exercise more. They often say, they don't look at the food first. They always just say, oh, I know I need to exercise more. But I'm sure that you could be able to tell people, I mean, exercise is very important for maintaining weight loss. Absolutely. And for helping, but you cannot really be successful long-term with weight management if you're exercising alone and not changing your diet. Is that right?
That's totally right. Totally right. I mean, if one is looking for weight loss is at least 80% or more diet. And only 20% or less exercise. And I think it's also, how easy it is to undo the effects of exercise. Like if I jog for 30 minutes or more, that can be easily undone by just a tablespoon of extra virgin olive oil or less than that. Right. So imagine how easily we can, do a little bit of olive oil in our salad. So it's so much difficult to burn off that excessive calorie intake with exercise. So diet is supreme.
I'm very happy that you were able to say that, 80% diet, 20% exercise for long-term weight loss. So how much time, I'm sure it has to do with weight, but since we decided that only 5 to 7% of weight loss would be adequate possibly for reversing or quote reversing some of these changes to the hormones, how much time do you think a woman should give herself to, if she knew that she had PCOS before she tried to conceive? How much
I would say that's dependent, and again, I want to make sure that our listeners, they ask their actual doctors, their own specialists about, individualized advice. It depends on their age, so if they are 40, I don't think they should wait a long time. If they are really in their early 20s or mid 20s, I think they can wait for maybe a year. And, if they are able to regularize their cycles, technically speaking, they would need, like maybe 6 or more good menstrual cycles in a year in order to have a fair chance at fertility, being able to conceive. So, if they're able to get their menstrual cycles to around 35 days or so by changing and, we have interventional trials, like I said, that, the trial on legumes, which was only 16 weeks. Within 16 weeks, many of their parameters, their fasting insulin, their waist circumference, their testosterone level, their menstrual cycles, they all got a lot better. And then there are a lot of studies on, like stress reduction, mindfulness. They see changes in women's quality of life or their, their fasting insulin, etc., within 8 weeks. The changes can happen pretty quickly. And it depends on how old you are and, where you are in your reproductive span. That would determine how long you should try before you go to a fertility specialist.
Very good point, because we definitely tell our clients, and I would always tell my patients, if they're 40, that they really don't have to delay and they can seek help. But the issue still stands that if you are obese when you're pregnant, no matter how they get you pregnant, but if you are obese and you're eating a high fat diet and you're gaining excessively, it's not going to be good for the pregnancy or for the baby. So it's really a balancing act. That's why we really want to reach people when they're much younger, so we can have a greater impact on the future generations.
I was watching a video and it just kept going, and it went on to another video, and it was an advertisement, and I was just horrified. It was talking about olive oil and how extra virgin olive oil is going to help you and help your arteries and help you to your heart healthy. And it's going to help you to make all these changes in your life, that in spite of the Mediterranean diet, which is high in leptins, the olive oil is going to help to make this work, and you're going to lose weight. And I'm just like going, oh my God, how eating 100% fat is going to help you to live? And it's no wonder that people are confused and having these issues. And you're just like, what, really? What is going on here? How can somebody, and think about, and it sounded very convincing, that the person at the other end was like, oh my God, you're going to change it, and there's definitely different qualities of, kinds of, extra virgin olive oil. And you want to get one that's, and I'm like, oh my God, really? Anyway, I just had to throw that in there because you're getting this olive oil. We're trying to get it out of your diet. It's going to clog your arteries. Your little red blood cells are going to not be able to flow through your arteries well. It's going to take 10 to 12 hours. So I know there's a lot of misinformation out there, but I just had to get that out.
Well, it's interesting. I've seen Dr. Joel Kahn, actually America's Heart Doctor. I've heard him talk, waxing a little semi-poetic about extra virgin olive oil. So have you heard that, Dr. Gulati?
So, I think the data and there are different cultures and they all have their favorite oils. And, like there are people who really swear by coconut oil in certain parts of Asia, or, ghee or clarified butter in certain parts of Asia. So every, culture has their favorite oils, and there are all these legends or myths about how these oils are health giving, right? And that olive oil is good for our skin, it's good for our heart, it's good for our arthritis or bones and so on, right? And I think the literature on olive oil, there's a lot of confounding there. I think, olive oil gets such a great rap because it keeps good company. So, when we go to a restaurant, they don't cook with olive oil, right? But when we are at home and we make a huge Mediterranean salad, that's where the olive oil comes, right? So olive oil comes with good company. Or we have freshly home-baked breads. Because, processed food, that doesn't come with olive oil. So, of course, if we take one type of food, we are talking about the standard American diet or the SAD diet, which is, croissants and donuts and, white breads and sugar sweetened beverages. And we compare that with homemade food or salads, and we are adding even a generous amount of olive oil. It's still going to be harm reduction. And possibly that's why olive oil gets to get its health food status. Or the same with other cultures, and there, if you're making home cooked food in coconut oil and stuff, that tends to, and coconut oil, I'm sure you've heard the great health stories about medium chain triglycerides and all that, right? The truth though is, there is no single superfood, right? Olive oil on its own has no merits unless if there is all these non-starchy, colorful vegetables along with it, or whole grains with it, or nuts and seeds with it. And so it's the totality of the diet, not really one food that is the magical ingredient. And as Jean mentioned, oils in general are inflammatory. There are, studies where if you just ate 1 tablespoon of oil, which is at least 120 calories, and then you went on to do the whole meal, that oil really doesn't decrease your calorie consumption at the meal. If anything, you might actually end up overeating because of the changes triggered in your body after consuming that much amount of oil unmitigated. Whereas if you do the same calories, 120 calories as an apple, and then you proceed to do your meal, you will end up eating less at that meal, because that apple has fiber, that apple has phytonutrients, and it actually triggers satiety. Oils don't do that. And they bring in a lot of calories. They are the most calorie dense, like 4,000 calories in a pound of oil. So, or maybe more than that, I forget exactly.
No, it is 4,000 calories a pound, absolutely.
The most energy dense foods known to mankind. And so, with oils, one has to be very, very cautious on their own. They don't really merit so much status. It's the totality of our diet.
Right. Although I would like to say about coconut oil, very dangerous oil. My LDL cholesterol, my total cholesterol went way up when I first became vegan, and a friend taught me how to roast my vegetables, but using a lot of coconut oil. And it tasted so good. But my LDLs went up to 120. And so when I took the Ruby cooking course, the Forks Over Knives cooking course, and I learned how to roast on parchment, and I just got the oil out of my diet and really stopped the coconut oil and stopped all oil, I'll tell you, my LDLs went from 120 to 60.
Wow.
The only difference was removing that, it's very high in lauric acid, it's highly atherogenic and really dangerous. So, maybe coconut oil is good for your hair, your skin, but I would not ingest it.
That's right. It is actually basically purely saturated fat with like some amount of medium chain fatty acids. So you're right.
Maybe you could just add one question. It's about something else though entirely people might be interested in. What do you think is the best way for women to get, because you are a thyroid specialist also, the 150 micrograms of iodine that they need before pregnancy? They also need a little bit more when they are pregnant, but when they're pregnant, I imagine they're going to be taking a supplement. But for just women who aren't taking a prenatal vitamin yet, how do you get your iodine reliably?
I was going to say prenatal for women who are thinking about getting pregnant. That is the safest way. They have to have a prenatal with iodine. But if for some reason they are not in that frame of mind where they want prenatal yet, they are not thinking about pregnancy, and they are super strict about iodized salt, they can't even, because, if we had like 3/4 teaspoon of iodized salt, that would get your daily recommendation of, iodine intake, at least in the US.
Yes.
If they don't want to do that, if they're super strict, then I think a multivitamin with 150 micrograms of iodine. And during pregnancy and lactation, absolutely prenatal. There is no doubt iodine deficiency is the leading cause of mental retardation and learning disabilities worldwide. 2 billion people are affected from that. So iodine intake as a prenatal or as a multivitamin, not an iodine supplement, that's because that's a whole another can of worms. Iodine intake through multivitamin or prenatal is supreme. It's absolutely important.
Absolutely. Thank you. Thank you. So you can't really rely, people do rely on sea vegetables, or they think that but it's just the amount is variable.
That's
so
right. That's right. That's exactly right. And it's kind of difficult to incorporate sea vegetables on a daily basis, right? Even in Japan, I think they only eat 2 or 3 times a week, which I think is one of the highest consumption of sea vegetables in the world. I think it's kind of difficult if we are looking at, places where they're not easily available. It's kind of hard even to get them at health food stores.
Right.
So prenatal is a must.
Excellent. Excellent. I would agree. Especially since you need so much more, actually, 220 when you're pregnant and 290 micrograms for lactation. So it might be a combination. You might have to add that little bit of iodized salt along with your prenatal vitamin to get it. Usually the prenatals have 150 micrograms, but they don't have more than that.
But you know what, I'll say there are many prenatals that don't. So women have to carefully
I know.
look. I can't believe that happens, but there are many prenatal vitamins that come without iodine.
Yes, we've had clients who've shown us their prenatals and they don't. And it's like, go out, you have to know, you have to get something else.
And iodine deficiency is actually a real risk in many parts of Europe and, many parts of the world, really. In the US, we don't do iodine deficiency that much, although now the trends are starting to get back to worrisome. But, worldwide iodine deficiency is the leading cause of hypothyroidism. Unlike in the US, we don't have that much hypothyroidism here from the iodine deficiency. So it's a real problem. It's a real problem. And one has to be very careful about checking their prenatal or their multivitamin and making sure that they are getting that if they're not eating any iodized salt.
Now, people who have dairy products, I think are taught that they're getting, well, I don't know if they're taught, but I mean, I think they imagine, or maybe they don't know, but they are getting some iodine through their dairy products because on the dairy farms, they're cleaning the equipment that they use for milking and cleaning the teats of the cow with an iodine, like a betadine, with an iodine-based salt. And so there is some iodine. Although, if you look at your milk carton, it certainly doesn't say that the milk contains an amount of iodine.
That's right.
But that's what. But that's what you've been taught also, that there's some iodine in dairy.
We have been taught that, when we do low iodine diets for people with thyroid cancer, when we're giving them radiation, we've been taught dairy is very rich in iodine. And I didn't know about the cleaning part. I thought they have a lot of iodine because they are actually given iodized feed. They're actually fed iodized, I think, soybeans or whatever they're fed.
Gosh.
In order to increase their iodine, because there is basically they want the dairy to be iodine replete. They don't want iodine deficient dairy.
That's so interesting. No, I had always been taught it's because they clean the cow's udders and they also clean all the equipment. They run it through with an iodine-based soap. I hadn't heard that they actually give the cow. That's so interesting. But then why don't they put it on the milk carton that it actually supplies some RDA, some proportion of the RDA? It doesn't.
I don't really know. I think, maybe because it's not an FDA requirement. I'm not sure. Because they don't mention a lot of other trace minerals either, like selenium, etc. The selenium is another one trace mineral, which is very important for thyroid health and, in general, cardiovascular health, immune health in general. But, maybe the FDA doesn't require it. That's why they don't disclose it.
Oh, very
but
interesting.
dairy in general, we can presume that it's rich in iodine, at least in the US. Elsewhere in the world, we don't know. Iodine deficiency is a problem, at least in Europe.
We could talk to you like forever, honestly. And so thank you very much. And you're going to be coming back December 21st, same time, same channel. So we're going to continue this conversation because it is so important. So
thank you so much for having me, Dr. Shapiro and Jean. It was really an honor and a pleasure, really.
Oh, really? It's fantastic. I would love to talk to you more anytime. And also maybe about if you ever want to do a study, if you ever want to do a prospective study using the pregnancy advantage, that would be amazing. I really want to help.
That I would, I'm definitely sure I'll be in touch with you for some collaboration down the road.
All right. Thank you.
Thank you so much for having me. I really appreciate it. Bye-bye.
We'll see you guys next week.